Hello,
Hello,
I'm Gideon Caplan,
I'm Anita Nitchingham.
and we're from the Australasian Delirium Association down here in beautiful downtown Sydney, calling out to you on World Delirium Awareness Day
Happy World Delirium Awareness Day.
2021.
Yeah,
And it's a big day in Australia.
huge day.
We always make a big emphasis on World Delirium Awareness Day,
Right.
try and increase people's awareness of delirium. And to go with the flow this year, we're doing it more online.
Right.
So we've recorded this little presentation for you, which we're going to share with you now.
Maximize it.
Maximize
So that
it.
we can.
Yes, that's a good idea. We're real computer wizards here. Okay. Now that's going to go up here, so just so we know where we are. So we've got the World Delirium Awareness Day logo, and we've got our Australasian Delirium Association logo on the bottom right-hand side there. And we're going to talk about how we celebrate World Delirium Awareness Day in Australia. We're not going to.
No COVID. We don't mention COVID. We don't need to mention COVID.
No, we've been very lucky in Sydney, and we hope that everyone else around the rest of the world is getting over theirs.
Absolutely.
But we're going to talk about some of our research, which we think you might be interested in. So, how do we mark World Delirium Awareness Day in Australia, Anita?
In many ways.
That's right. Now,
Anyway.
many people will be familiar with these Australian icons, and they're really pulling out all stops.
That's right.
And you can see the latest images of the Sydney Opera House, now embossed with the World Delirium Awareness Day message.
Yeah, artistically beautifully done.
It is.
Yeah.
It is very tasteful.
Yes.
And so other icons of Australia wanted to get up on this as well. And you can see they're moving towards recognising WDAD.
Yes.
Hop to it, as they say.
Good one.
Yes. Which then allows us to move on to some more serious content.
Absolutely.
We're going to talk about some of the costs of delirium that we've been studying, which we think is a very important message that has to be gotten out to the rest of the world that's not as focused on delirium as we are, and they don't always realize how big the costs of delirium are. We're also going to talk about
metabolic aspects of delirium, so pathophysiology, we're a little bit interested in.
a little bit, yes, yes. We do like to talk about that. So why should we consider the costs of delirium? Well, as I mentioned, if people don't really understand about delirium, it's hard for them to recognize the impact of delirium without quantifying it. That's how the world works nowadays. And we can have things that are very similar but have very different costs. For example, common cold can be caused by coronavirus, as can that other thing that I'm not mentioning. So obviously they have completely different impacts and on the world and very different costs. So we've paid a lot of attention to what's happening this year with our coronavirus, but not with our common cold.
That's right. I think understanding the costs or the outcomes for patients relevant for educating family members and bringing you on that journey and prognosticating, and I guess the more information you know, the more you can talk to them about it as well. So
that's right. It's very important that we help carers to understand the effects of delirium. And for a long time, people didn't recognize that delirium is associated with increased mortality and significantly increased disability, both cognitive disability
and functional.
Yes, so dementia and loss of activities of daily living function, as well as some effects on mood, which are not so well quantified.
Psychiatric effects, distress.
Yes, both I think directly and also as a reaction to the resultant disability.
Absolutely.
Very important to consider. And to understand the impact of delirium, I think it's good to look at what's been happening with other diseases that we treat, so that we can contextualize ourselves, such as the big ones: cardiovascular disease, cancer, COPD, to name a few, just as examples.
Mhm.
And it's very interesting when you look at what's been happening with cardiovascular disease over the last 40 years. It's a dramatic decrease in mortality.
Very impressive.
This is data from Australia, and really our cardiologist friends should be congratulated, because they've cut the mortality by more than 2/3 over the last 40 years. And if we look at what's happening in cancer, we can also see a drop in mortality, particularly over the last 25 years, I'd say,
Yes.
as treatments have improved, and other factors, which we'll talk about soon.
COPD
Yes,
also looking better and improved from the 1980s.
yes.
But the rate for women,
The smoking rate for women seems to be going up still.
where's the COPD rates going
Oh,
up?
COPD
The smoking
rates,
rate's
sorry.
going
Smoking
down.
rate's
So
going
maybe
down, that's
over
right.
like the next 10, 15 years.
Yeah, yeah.
The COPD rate might.
But the COPD mortality rate has dropped by about, well, more than a half for men, certainly. For women, it's coming down. Oh, it's not coming down, so it's going up.
Yeah.
Lagging behind the increase in smoking. But you suspect it will as the smoking rates continue to drop in the Western world, certainly. But we know that mortality doesn't just decrease because of better treatment, although when it decreases on a population basis, you'd think it is a big effect of prevention and better treatment. But sometimes you can also get an effect just from changes to the definition. That is, people include milder cases, broaden the definition, and also screening it better leads to detection of less severe cases.
And I think with all of our great efforts in delirium that, we do, I would think, we detect much more milder cases of delirium, detect much more delirium in terms of hypoactive delirium as well.
Absolutely.
Potentially that would impact the overall appearance of mortality.
Yes,
Yeah.
yes. But we've recently conducted a meta-analysis, and it shows something a little bit different with data from studies. And obviously we don't have population-based data for delirium because we know that it's vastly under-recognized.
Yeah.
So the best data we have is from studies that have actively screened and looked for delirium. And these show that over the last 30 years, statistically, there has been no decrease in delirium mortality.
Yeah, so this is in patients over 65 across different
Medical and
settings.
surgical wards. This doesn't include ICU, because we only found 2 studies that measured delirium mortality in ICU, and they were both very recent. So it's actually a bit depressing to know that we have made no impact on delirium mortality, but we describe it as a
call to action.
That's right. This is a call for all the young delirium clinicians and researchers out there. This is a challenge you need to take up. Like Anita, yes.
Sorry.
Yes. So that's very important. And this also allows us to think about the costs of delirium, although mortality probably actually decreases the cost of delirium. If you don't need to care for someone who's dead, you've just got the funeral cost, but the overall costs can decrease due to mortality. But obviously a lot of people do survive their episode of delirium, and we know they have longer lengths of stay.
Yes, it's double.
So they have increased acute healthcare costs, both to the patient and their carer, and to the healthcare provider.
That's right. In
Australia, hospital systems funded by the government, but in other countries it might be through insurance companies. Then there can be chronic costs after the delirium is resolved as a result of the dementia and disability.
Right. Okay. Nursing home care, institutionalisation, and home care services.
Yes.
Loss of ability to work for carers.
In some cases, loss of ability to work, even for patients sometimes.
Yeah.
But also definitely for carers. Yeah. It's a cost that has to be taken into account. And when we divide it up in Australia, who pays the acute care costs, you can see most of that acute care cost is borne by governments in Australia, but this picture would be probably different in some other countries. But you can see the average cost for a person with delirium, extra cost on top of what someone with the same level of illness, the same level of comorbidity, same age, the extra cost attributable to delirium is $13,000 per person with delirium.
Which is massive when you think about how common delirium is.
So we calculated 100,000 cases of delirium a year, more than 100,000 cases of delirium a year in Australia alone, based on incident studies. So that if you multiply 13 by 100,000, you can see you get quite a big number already just from the acute care. But then there's also the chronic care. And when we look at the total costs of delirium, we can actually see that more than 50% of the costs of delirium are attributable to the need for ongoing care, especially when people progress to dementia.
Yes, or even people with dementia that reach the point where they then need to go into care, or they suddenly lose function that tips them into the next stage.
Because we know delirium accelerates the progression of dementia. And when we add up the cost of all these factors, we're looking at a total cost for Australia of nearly $9 billion a year, which is quite a big number. Yeah, substantial cost to the healthcare system, to patients and to carers.
Money talks sometimes. So for our politicians, that's right. Significant.
It is very significant. Yeah. So people may not realise how much delirium does increase the onset of dementia. So we actually looked at that in a study that was published just this year, fresh off the press, and then in a meta-analysis of 6 studies, 2 of which only came out very recently. And it's surprising that the odds ratio for new dementia in people who didn't have dementia beforehand after an episode of delirium is nearly 11.942. It's one of the highest odds ratios I've seen, and it just shows the interlinkage of delirium and dementia.
So whether delirium's unveiling, undiagnosed or not undiagnosed, but dementia that's preclinical,
yes,
and or whether the delirium is actually causing injury to that time, maybe a combination. We don't know yet.
Look, it's a continuum. It is. There's a spectrum. But in all these studies, they looked at people who didn't have delirium as far as you can measure it beforehand.
Dementia.
Sorry, didn't have dementia. Yes.
Yes.
The new onset of dementia feeds into people who need nursing home placement, and this is unpublished data yet, so that's why we've got that no tweeting sign up in the corner. But we hope to get this published soon. It's under review, I think.
Yeah.
But it shows, yes, more than doubling of the rate of nursing home placement with delirium.
One of the major concerns for our patients, I think.
Most of our patients would tell us they'd rather die than go to a nursing home, which is very sad. But it just shows we've got a lot of work to do to prevent delirium. And that illustrates how that's a big driver of costs, nursing home care, because obviously that's 24/7 care. So we might move on to
delirium pathophysiology.
Yes. And we've been working on that now for some time, about 15 years. And we discovered by accident, really, that people who have delirium have increased levels of lactate in their cerebrospinal fluid, in the CSF, and decreased level of neuron-specific enolase, which was a surprise.
What does that mean?
It's a good question, Anita. Thank you for
great.
asking. Yes. Well, it's interesting that we found that the level of lactate in the CSF correlates with outcomes of delirium. You can see that people who died during the episode of delirium had higher levels of CSF lactate. And this was taken, the CSF was taken an average of 5 days before they actually died. So this wasn't a sort of ante-mortem finding that was compared to the people who eventually went home. And it also correlated with the level of functional decline that they developed during the course of that admission, looking at their instrumental activities of daily living. We also found that the level of lactate correlated with indices of their acute illness, like the Apache, as well as measures of their delirium severity, like the extended version of the CAM and the delirium index. And this has been replicated now in another study by Colin Cunningham's group, who replicated the increased level of lactate in the CSF in people who had delirium, as well as an increased level of pyruvate. You can see on the right there, whereas the CSF glucose wasn't elevated, which was also what we'd found previously.
FDG PET?
FDG PET.
Okay. So I guess we think that there's some metabolic disturbance in the brain during delirium. And we have FDG PET, which allows us to, I suppose, map out and analyze what's happening in the brain. This is a functional neuroimaging study. So this is a brain, I think, of somebody with delirium.
It is.
You can see some purple, more darker colours, and some brighter colours there in the centre. So FDG itself is a glucose label, a glucose molecule that's been labelled. So when glucose is taken up by cells, it's trapped in the cell. So when you take through imaging, you can see where there's more glucose uptake, and we say that studies show that more glucose uptake means more neurotransmission and synaptic function. So you can map out parts of the brains that are more metabolic or less metabolic. So here you can see the purple parts for the most of the brain, so that's just low areas of metabolism. And then this strip in the middle there, which I think in this study was the sensory motor cortex, showing quite either normal metabolism or hypermetabolism. It's difficult to tell because it's quite relative. So that kind of explains, well, we've kind of talked about what FDG is, but we do use FDG PET clinically to help us diagnose dementia sometimes. So dementia is often a clinical diagnosis, but there are certain dementias that have specific patterns within the brain based on what areas of the brain have been affected. So typically Alzheimer's dementia has the temporal lobe affected and the posterior cingulate cortex. Frontotemporal dementia has the frontal lobes that are predominantly affected. And in fact, hypometabolism in the brain in people that have normal cognition can actually predict dementia, and it can predict mild cognitive impairment, the conversion of dementia. So over the years, the metabolism in the brain becomes worse.
And it's interesting that the FDG, the level of FDG metabolism or detected on PET scans correlates better with the level of and the risk of getting dementia than the level of amyloid in the brain. Yeah. So what's this showing, Anita?
So on the left, we have a patient that's undergone an FDG PET scan whilst they're delirious. And on the right is a control or a normal patient, or a patient that doesn't have delirium. And you can see.
And they weren't in hospital.
And they weren't in hospital. So
That's right.
Yeah, healthy controls.
Yes.
So you can see on the left, the patient with delirium has more purple, which means there's less glucose uptake in that part of the brain, particularly grossly looking, you can see over the cortex, but mainly the frontal, even on this image, it does look just a bit occipital, but that sensory motor cortex seems to be relatively preserved. And you can see on the right, the normal brain, you can see that nice even distribution of FDG uptake throughout the cortex.
Very symmetrical.
Yes.
Beautiful.
Yeah.
I hope that's my brain.
Me too.
Yeah.
So these were the areas that we found to be affected.
These were so when we repeated the scan after 3 months,
yes,
we found that the glucose uptake improved with the resolution of delirium.
That's right.
That's right. In all areas. And this is a scan of a different person who had delirium.
Yes.
During the episode of delirium. And then 3 months later.
Very impressive.
It is.
Yes, you can see all of that glucose uptake compared to while they had delirium.
So it's much better post delirium.
Yeah.
But is it back to normal?
Well, probably not compared to healthy controls.
Yes.
Unfortunately, we don't have baseline imaging. So
before delirium.
Before delirium to determine if it is back to normal or whether it's kind of a little bit lower than normal. It's certainly better, but potentially if it doesn't return back to normal, whether that does explain some of the ongoing persistent delirium or ongoing cognitive decline following delirium.
And we can see even 3 months later that there's that prominence of the sensory motor cortex, which could be a little bit of hypermetabolism or normal. I'm not sure. The values you get from analysing FDG PET scans are relative values, not absolute values. So you can only say what's happening compared to other areas.
Yeah, so then we thought,
could these changes be due to acute illness rather than delirium?
A number of neuroimaging studies have demonstrated that during acute illness, particularly in sepsis, you have reduced perfusion and even reduced metabolism.
Yeah.
So you need to consider that and potentially control for that if you're going to attribute this to delirium rather than acute illness.
And we know from our own experience that when you're sick, you're not firing on all cylinders cognitively. That's why we have sick leave. That's one of the reasons why we have sick leave, so that you can stay at home while you're not really functioning at a high level.
Right.
Yes. But how do you control for those changes?
You scan people who are sick but don't have delirium and don't have dementia.
Correct. So we did this subtraction.
Simple takeaway.
Simple takeaway. This is takeaway message. So we have one group sick in hospital who have delirium but no dementia, and the second group who are sick in hospital with no delirium and no dementia. And we subtract the second group from the first group. And what does that give us, Anita?
Very simply, we found areas of hypometabolism in delirium that wouldn't have been attributable to acute illness.
Correct.
That both groups had acute illness. So these were the areas that we found, and this is under review at the moment, but you can see the right superior frontal gyrus. So the frontal lobe we often associate with executive function,
yes,
but also kind of reasoning and judgment. It also has some connectivity to the default mode network, which is quite. There's other studies that show that potentially that's abnormal in delirium. The right posterior cingulate cortex, which is a key part of the default mode network, was also hypometabolic. And
for people who don't know what the default mode network is, you want to
sure
tell them about that?
So the default mode network is a network of different parts of the brain that are more active at rest. So when you're not attending to something,
they're scanning the environment.
That's right, in the background.
Yes.
When you're daydreaming.
Very metabolically active.
Yes.
Normally.
Yes.
But in delirium, they were less metabolically active.
Yes, exactly. The temporal lobe, and that particular part of the temporal lobes associated with semantic memory. So potentially some of the communication errors that we have during delirium that could explain that in language errors. And then suppose one of the most significant findings was bilateral thalami,
Not thalami?
not thalami,
No.
and not bilateral thalamus.
No.
It's a bit controversial what we should write there, but bilateral thalami.
Thalami, yes, and the thalamus is very important for filtering,
That's right.
allowing us to concentrate on one thing and blocking out all the other signals.
Yes. So it filters everything from the cortex and enables selective attention.
Yes, as well as sitting at the top of the reticular activating system.
Yes.
So it's very important for consciousness, for alertness.
Yes.
And obviously, those are two key features of delirium. So the thalamus is clinically, you'd suspect it to be involved in delirium, and these PET scans show that it is absolutely involved, hypometabolic, not working properly in delirium. And that's interesting because of the thalamus's lack of involvement in other conditions.
Yes, yeah. So I suppose some of the cortex, particularly the posterior cingulate, the temporal lobe, and even the frontal lobe, particularly the posterior cingulate temporal, is involved with Alzheimer's disease. So you could say, oh, well, what you're finding could be somebody that might develop dementia in the future and has early changes with Alzheimer's disease.
Yes.
But the subcortical regions and the thalamus are typically spared.
Yes.
So whether that is unique to delirium and can be attributed, like the symptoms of delirium can be attributed to hypermetabolism of the thalamus.
I think it shows us that delirium is a separate condition, related but separate to dementia, and that it's got its own pathophysiology. It's not just that they have dementia, no one realized it. They've got delirium, it's a separate condition.
Yes.
But it feeds into dementia, and dementia feeds into delirium as well. So they're clearly linked, but they're also, it has its own identity. And I think this very clearly shows that delirium is something we have to take special account of. And we could show this not just by our knowledge that people are less alert, less attentive. We also correlated this with neuropsychological data.
Right. So we looked at the metabolism of the thalamus and mental control. So mental control measures aspects of attention and working memory. So you ask a patient to count forwards and backwards from 20, do months of the year forwards and backwards, do days of the week forwards and backwards, and you time them to see how long it takes. And you can see there that the lower the metabolism, the worse they actually performed on cognitive scores.
And that's, you can see obviously this is a small group, but that's it's, you know, you can definitely see the pattern there. We're not just imposing that line on the data. No. And we've got similar data for a lot of other neuropsychological tests, but in the interest of time, we're going to move on to talk about what this means for delirium pathophysiology.
Take it away.
All right. So, I mean, we know that many things can trigger delirium and are risk factors for delirium, but we suspect that from the findings we have that cerebral hypometabolism could be the final common pathway for delirium pathophysiology, which may give us, you know, something to aim at, give us a target. Can we treat cerebral hypometabolism to turn around, to prevent or to treat delirium? So this is a possible alternative therapeutic target to giving antipsychotics or other sedatives when you actually want to wake the brain up, make the brain work better, not quiet the brain down.
That's right. And all those causes of delirium really result in a recognizable syndrome. So it could be that they all lead to the one pathway. Could be.
Yes, exactly. If they're all different, you'd expect different clinical syndromes.
Essentially.
Yeah. But we haven't worked everything out. There's plenty left for other researchers to discover. in Delirium. And if you've got some great findings from your Delirium research, where should you bring it, Anita?
To Brisbane.
Brisbane, it was going to be in 2020, but now it's in 2021.
Yeah.
It's still in September, but now it's the 8th to 10th of September 2021 at the beautiful Brisbane Convention and Exhibition Centre on the river in beautiful downtown Brisbane.
Yeah, it's lovely, tropical.
Yes, Brisbane's in Queensland, which is full of the Great Barrier Reef. You've got tropical islands,
Yes, great beaches,
spearfishing, scuba diving, beautiful rainforest,
got it all.
hiking. Yes,
Yeah.
magnificent, magnificent. So come and join us.
Yes, hope to see you there.
Absolutely.
Have a good World Delirium Awareness Day.
Thank you,
Thank
everybody.
you for having us.
Yes.
We get to go to more